During cardiac arrest, a victim's heart suddenly stops beating. Most victims who survive cardiac arrest outside of the hospital are resuscitated at the scene through advanced care by EMS crews. But what should happen when a victim doesn't respond? Cardiac experts at the University of Michigan have determined a single standard guideline for action would reduce unnecessary transport and open up resources in the emergency room.
There's about 166,000 cases of cardiac arrest in the United States each year. About 60% of these are actually treated by emergency medical services. What we find is that there are certain patients who are futile resuscitations and have no chance of surviving a cardiac arrest. What happens is that these patients needlessly get transported to the emergency department for further care. What this does is actually displace resources from the out-of-hospital setting, so community members aren't able to get ambulance services because there's an ambulance that's transporting someone to the hospital. You also find EMS personnel who are needlessly endangering their own lives by going lights and sirens on, increasing their chance of getting into motor vehicle collisions. Physicians, nurses, techs will all crowd into a room of a patient who's a futile resuscitation, and we no longer can take care of the stroke that comes in or the heart attack that comes in. And these are all patients who, time is critical, and we really aren't able to help them because we're working on somebody else who really has no chance of survival. Here at the University of Michigan, we looked at a study that looked at 2 rules predicting which patients should be transported to the hospital. The 2 rules basically have five criteria. The first rule basically says that if an arrest is witnessed by an EMS provider, if a patient has a shockable rhythm, meaning that we can actually put the paddles on and give them a shock in the out-of-hospital setting, or if they have a pulse in the out-of-hospital setting, then they should be transported to the hospital. The second rule just added 2 extra criteria and basically said that if a patient had bystander CPR or had an arrest that was witnessed by a bystander, then they would meet the criteria to actually be transported to the hospital. When we applied these 2 rules to our own cardiac arrest registry, we found that we were able to predict almost 100% of the time which patients should be transported to the hospital. Time is brain, time is heart, and now we actually have the time and the resources to focus on these folks who we can actually help.